Good morning, everyone. Hopefully, people will start remembering that Grand Rounds is back to 8 a.m. and not 12 anymore. I'd like to welcome you to today's Grand Rounds, which is in order in honor of World Kidney Day / World Kidney Month. World Kidney Day is actually next week. And I'm really pleased to introduce our speaker for today, Dr. Susan Firth. Dr. Firth is Professor of Pediatrics and Epidemiology at University of Pennsylvania, and she's Chief of Nephrology at Children's Hospital of Philadelphia, where she's been since 2010. In addition to that, she's Vice Chair of the Department of Peds there and holds the Lucy Connolly Endowed Chair at University of Pennsylvania. Her education, I'm just going to be very brief here, so she has her allotted time for talk, but she received her BA at University of Pennsylvania in English, her MD also at University of Pennsylvania, and did her residency and fellowship up the street at Johns Hopkins University, where she also did a PhD in clinical investigation at the Bloomberg School of Hygiene and Public Health. I know Dr. Firth very well, professionally and personally. She is principal investigator of the C-KID study, which has been going now since 2003, and is also PI of the CHOP Pediatric Center of Excellence in Nephrology, which its goal is to help people to do more and better clinical research in peds nephrology. She has close to 300 publications, an excellent mentor. I could go on and on, but I won't. So I'll ask you to welcome Dr. Firth to the podium.
Thank you, and thanks for that kind introduction. I'm so pleased to be here today in celebration of World Kidney Month. So March 14th is World Kidney Day, and I just thought I'd start out with some general facts about kidney health in the world. So although kidney disease is uncommon in children, worldwide 850 million people are affected by kidney disease, and chronic kidney disease is really the 11th leading cause of death in the world. So there's a number, you can follow a lot of these information on World Kidney Day if you go to the International Society of Nephrology website, and at the very end we'll also talk a little bit about World Kidney Day. So what I'm going to talk about today, I wanted to make it relevant for the trainees in the audience and general pediatricians and pediatric subspecialists. So we're going to talk about best ways to assess kidney function, new estimating equations for kidney function, and when you have a patient in front of you with kidney disease, what can we tell people about the future and about their potential outcomes? So I'll start with a couple of cases, and these are actual children that I took care of during my training and as a pediatric nephrologist. And the first, and I can see them and their families when I talk about them. So the first case is an 11-year-old girl who presented to her pediatrician's office complaining of gross hematuria. And she had no swelling or anything, but when it was measured, she had significant levels of proteinuria. At that time, she was referred to nephrology. She underwent a kidney biopsy. After the biopsy, which I'll talk about, she actually later on developed a clinical rash that looked like HSP, Hennek's-Schönlein purpura, so with a rash on the buttocks and the legs and joint pains and belly pain. Her kidney biopsy, which is common in HSP, had a lot of IgA deposition, so it was consistent with IgA nephropathy. And she actually also had evidence of really active inflammation with cellular crescents. So because of that, she was treated with pulse steroids and then CellCept. So as a nephrologist, how do we assess how we're doing as far as the kidney function? So how do we assess the success of our therapy? Because this is a kidney-focused inflammation. And as you know, glomerular filtration rate is really the best measure of overall kidney health. And glomerular filtration rate is the rate at which plasma is filtered from the glomerular capillaries into Bowman's capsule per unit time. And on average, a normal GFR, if you directly measure it, is somewhere between 100 and 125 mils per minute per 1.73 meters squared. We don't normally measured kidney function. But this child enrolled in the CHILDREI study, which Marva just mentioned, and actually measured her GFR. And we've been very fortunate in CHILDREI to follow people over time. And what we have here is her kidney function when shortly after her biopsy. So it was diminished, but remained fairly stable. This is her chronologic age on the x-axis. So she was fairly stable for a number of years and then had a fairly persistent, not accelerated, but slow and ongoing decline over that time. So when you're taking care of a patient like this, how can you tell them how they're doing, and how can you tell, could we have told the mom or the child back here what our expectations were over the long run? And were there things that we could identify that helped keep her kidney function relatively stable here, and then explain that decline that perhaps we could intervene on earlier? So that's what I'll talk about today. The second case, similarly, was a 10-year-old female who presented, she just was not growing, and she went to her pediatrician, and in the evaluation of short stature, she was found to have an elevated creatinine and was then referred to nephrology. So in the evaluation of her poor kidney function and poor growth, she was found to have an ultrasound that showed small scarred kidneys with evidence of prior reflux. So she also had underlying kidney disease. She also was part of our study. And you can see here, again, she had diminished function when she presented and stayed fairly stable for quite a number of years, 7 years. She was coming back for a study visit, or we called her to come back for a study visit before her 21st birthday. And unfortunately, she had moved in. She had been living with her fiance, and we reached him, not her, and he let us know that she had died, actually unexpectedly. The family was told it was a cerebral hemorrhage. We don't know the actual cause of death, but we know she had had terrible problems with blood pressure control in that follow-up. So I use this as an illustration about one of the major outcomes in chronic kidney disease. Unfortunately, in addition to problems with kidney dysfunction, cardiovascular disease and cardiovascular disease morbidity and mortality are some of the major contributions to death, particularly in the adult population, but also in children with kidney disease. So if we want to be able to explain to children and families what does the future hold when we diagnose them with chronic kidney disease, how can we study this? It's challenging. Kidney disease has many causes in children. There are multiple comorbidities. Children don't grow well. They have some, particularly those that are affected when they're infants, have substantial or may have substantial developmental delays. As you saw it here illustrated here, there's a high risk of cardiovascular disease and death, sudden death actually in adults. And kidney function declines, as you saw those two examples, it can be very slow or it can be quite rapid. So what we did was many years ago embarked on the chronic kidney disease in children study. Marva was a big part of this for many years when she was at the NIH. It's an observational cohort study. We started in 2003, and we've been fortunate to be renewed several times, most recently renewed in 2018 through 2023. And we've enrolled 3 waves of cohorts, and you see here the descriptions, generally between just under 1 to 16. We were initially trying to target mild to moderate kidney dysfunction, but we got more severe kidney dysfunction. So then the second cohort, we tried to get more mild kidney dysfunction. And the third cohort, we targeted younger children. And we're just finishing enrollment of that cohort now. So as a teaching point for what causes kidney disease in children, the causes of kidney disease that we see in the CHILDREI study are quite representative of what kidney disease looks like in children. Overall, we consider 2 big categories, underlying glomerular diseases, like the first case that I showed you. The most common things are FSGS or things like HUS or systemic immunologic diseases like lupus. Those are the most common causes of glomerular disease. That comprises about a third or maybe 40% of kidney disease in children, sort of depending on the age group. And then non-glomerular disorders are much more common, predominantly congenital anomalies of the kidneys and urinary tract, CACET. So what you see here, obstructive uropathy, that's most often posterior urethral valve, aplasia, hypoplasia, dysplasia, reflux, or there's some, many of these, they overlap. And that second case that I showed you was probably either a combination of reflux or aplasia, hypoplasia, or dysplasia in that child. So I mentioned, we're trying to preserve kidney function. What are the best ways to assess kidney function in the clinic? So you can measure GFR using an exogenous marker. So as you all remember from medical school, you give a marker that's freely filtered and neither secreted or absorbed, and you can measure the GFR. In our study, and I'll show you in a minute, we use iohexol as an exogenous marker to directly measure GFR. You can also use endogenous markers. These each have some problems. Creatinine, it reflects often muscle mass. So as you know, as you get bigger, your creatinine goes up. So it's a problem in children to estimate GFR directly from the creatinine. And cystatin is another marker you may also be familiar with that measures, it's a product of a housekeeping gene and is also freely filtered. It's actually stored in the proximal tubule, so you can't measure it in the urine, but it's also a good marker of kidney function. And using these and other markers, you can develop estimating formulas that I'll show about. So directly measuring GFR, I mentioned that we use iohexol. That's also, you'd know it as Omnipaque. It's a contrast agent. It's actually very gentle on the kidney, but it is freely filtered and neither secreted or absorbed. So you give an exogenous marker, and as you can imagine, this is a graphic showing the concentration and the time in minutes. So if something's cleared quickly, if your kidneys are working well, and this is completely cleared by the kidneys, you would imagine first it's distributed, and then it would decrease very quickly as it's cleared. And if your kidneys aren't working, then this would be higher. It would be distributed in this fast part, but then this very slow distribution in the longer way. So if you do the integral under here as the denominator, and you know the total dose of iohexol that you give, you can calculate the GFR. Actually, now just measuring 2 points on this slow curve. So that's how we directly measure GFR. But who can do that in clinical practice? You may also be familiar, similarly, glofil or iothalamate is another commonly used exogenous marker in radiology. Also, people use DTPA, but they each have some problems and limitations, but also it's just cumbersome to do in clinical practice. So clinically, we're used to looking at creatinine, again, something that's made every day in your body. It's filtered. It is, however, secreted at lower levels of GFR. But the problem with using creatinine, and we know this as pediatricians, this is from review in adults, but at any particular, this is serum creatinine on the y-axis, and this is the measured GFR. So at any particular creatinine, and this is an adult, so creatinine here of 1.5, could really reflect, if you measured the GFR, depending on that person's body habitus, something anywhere from 30 to 90 points. So that's not helping you a whole lot. So, and we know this intuitively in children, because you see a 2-year-old with a creatinine of 1.5, you know that means something different than, a 18-year-old very muscular individual. So our other endogenous marker that we use more and more frequently is cystatin C. This is, as I mentioned, it's a product of a housekeeping gene, so it's made all the time. It is all cells with a nucleus produce cystatin C, and it's found in virtually all tissues. It's freely filtered, and so it is another marker of kidney function and not reliant on muscle mass, so that is helpful. But similarly, from that same review, again, there's a little bit less of a spread here, but even as comparing measured to serum cystatin C, you can also see just using the cystatin of 1.5, again, that represents a very broad range of measured GFR. So that's additionally by itself a little bit problematic if you really want to have precise estimates of GFR. So within the C-KIDS study, since we measured GFR, we measured cystatin, and we measured creatinine, we developed formulae to estimate GFR in this population. So this shows the relationship between cystatin 1.8 actually over cystatin C and the measured GFR. You see a nice correlation. There is, however, a fair amount of spread, again, showing that for any given cystatin, you may have quite a range of GFR. And similarly, you're familiar with the Schwartz, it's a constant times the height over serum creatinine. And in the C-KIDS study, this was, the constant we initially came up for. Again, great correlation, but a fair amount of spread. So how can we improve on these things? This is the bedside formula for C-KIDS. So you have, creatinine is readily available in clinical settings. So we use this is height in meters, but often we're thinking in centimeters. So 0.413 times the height over the serum creatinine. It's a useful clinical tool. It is relatively imprecise. This is pretty good for a formula, but 80% are within 30% of the measured GFR. So it's a little bit better than hitting the broadside of the barn. So I mean, and only 37% are within 10%. So it helps guide you, and it works. Actually, it was developed in kids with chronic kidney disease, so we know it works fairly well in this range. But for kids with more normal kidney function, it clearly underestimates. So it's a little bit of a problem using this in the healthy kids walking around because you can significantly underestimate GFR with this formula. Using other markers of kidney function that we have, if we combine the height over serum creatinine measure and cystatin, also with CUN, and including a term for gender and another term for height, we can actually improve on the precision and accuracy with 91% within 30% and 50% within, I don't know how to get rid of that, 50% within, there we go, 10% of the GFR. Cystatin, as I mentioned, is less dependent on muscle mass. So and it's one of the problems with cystatin in the past has been that you could get cystatin in many different labs. The methods would be different, and they were not necessarily calibrated to the same standards. So it would be sometimes difficult to, you're not always measuring exactly the same thing. So more recently, there have been this IFCC group, which does calibration of these measures, has developed some standards for cystatin C, and within the CKID study, we've gone back to calibrate the cystatins that we've measured over the years and the measured GFRs. And this is our estimating formula within CKID. This is actually, usually you'll see cystatin C in mg per liter. This is actually in mg per deciliter. So if you made this 0.8, that would, the usual measure of cystatin C that you would get, you could use this estimating formula. So another alternative, and I understand you have cystatin C available in your lab here to turn that around. Lost my forward motion. Click. Thank you. I've done this before. Okay. So another problem that many of you, if you followed children with any kind of kidney insufficiency, may have noticed, if you use these pediatric equations to estimate GFR, big problem when they turn 18, because we developed our equations in children up to the age of 18, and the adult equations were developed in large populations of adults. It actually turns out the median age of those adult populations is about 40 or 50. So there's a big gap where we had little knowledge about how to measure GFR or estimate GFR in this population. So one advantage of having a long-term cohort study like the CKID study, we continue to measure GFR and follow these children as they become young adults. So we had a fair number of kids who were 17, 18, 19, 20, up through 24, and we were able to compare the equations developed in children and those developed in adults in this population in whom we had a gold standard measure of GFR. So it's hard to read. These are the equations, but I'll point out creatinine is what we usually have available. So this is that CKID bedside creatinine formula, the 0.413 times the height divided by the serum creatinine. This is the adult creatinine-based formula. It's called CKD EPI formula. Pretty complicated. Can't do it in your head. But there are a lot of, maybe some of you could, but there are calculators online. Like if you go to the National Kidney Foundation, you can find a GFR calculator. So this is the adult formula. And then this is what we think is the best approximation from the CKID study to measure GFR. So I'll call this the eGFR 2012 formula, and includes creatinine and cystatin and those other, BUN and another marker for height. So that's our most precise formula for measuring GFR in children. So this is an illustration of what you may see if you follow 17, 18-year-olds. They all of a sudden become 18. You've been following them. This is age 11 to 18. The GFR wanders around. There's some measurement error in any test. And then if they become 18 using CKD epi formula, all of a sudden they're doing pretty well. This is probably not biologically plausible. And then for the C kid, it actually looks like they're doing worse. So it looks like so it seems that both have biases if you would think that this trajectory was actually continuing. So we used the kids who had become young adults and had measured GFR. So we had 548 person visits from 219 people. And iohexol was directly measured in 279 of these person visits. So there was 187 folks. And you can see the age, the interquartile range, about 40% female, 20% African American. So this was the group that we could compare these different estimating formulas. And what you can see, we are in the dark blue is what we think is our most precise measure and which most approximated the iohexol GFR is that long C-KID formula with creatinine and cystatin. Here's the creatinine-based child formula and the adult creatinine-based CKD epi formula. And it turns out, which is kind of a clinically useful tool, that if you average this CKD epi and the CKD serum creatinine with the readily available creatinine, both of those formulas, you come very close to what we think is the best estimating equation. So again, a little clinical useful pearl. This was published in May of 2018 in KI. So, but a clinically useful tool when you're bridging that gap, as we follow many of these kids now from age 17 up till the mid-20s even. And this shows using that average of the CKID creatinine and the CKD epi creatinine eGFR, the average compared to the measured iohexol GFR. And you see pretty, again, not perfect, so there's some play around the line, but this is the line of identity. So again, the biases counteract each other, so it's a helpful estimate in this population. So this summarizes that if you have creatinine, cystatin, BUN, and height, that the larger equation is probably the best. But if you have creatinine, you can use those other two equations and take a simple average in this population. So getting back to our cases, we had those kids in front of us when they were 11 and 12 years old. What might we be able to tell people about their predicted progression? Parents want to know, are we going to need to do dialysis? Are we going to need to do a kidney transplant? Often the first time they show up to a nephrologist, they know they have some kidney dysfunction. They're asking, should we get all of our relatives together to find out if somebody can be a donor? And many times that's years off. So how can we predict how these children are going to do over the long run? And from our observations in the CKID study, there's clearly variability, but there are some things that help us predict. So I showed you in the beginning that about 30% of the kids have glomerular disease and CKD, and about 70% have non-glomerular disease. Here, those glomerular diagnoses like FSGS, lupus nephritis, immunologic diseases, they're pictured in blue. This is FSGS. This is other glomerular diseases, and these are modified box plots. So you're used to seeing like rectangles with a median in the middle, and then the tails with little lines. This is a visual representation of the distribution of the data. So the median is here, the 50th percentile, and then the 25th is here, the 10th, 5th, and 2.5 percentile. So you see that for glomerular diseases, overall, the median's about 10% decline. But you see this really remarkable heterogeneity of decline. But there is something, this is HUS, which they probably have an acute injury that then generally goes away. So maybe it's not that surprising that that group functions more like these kids with non-glomerular disorders that have presumably low nephron mass and have some hyperfiltration. And unfortunately, since you can't grow new nephrons, those nephrons that work harder end up scarring, and they have a slower but consistent decline. So you can see these kids with glomerular diseases, obstructive uropathy, aplasia, hyperplasia, dysplasia, even reflux nephropathy, they're all declining more similarly, around 4 or 5% per year. And if you look overall, again, the advantage of following these kids for a long time, the blue is the glomerular diseases and the brown is the non-glomerular diseases. And this is years from disease onset. So if you think broadly, just as the population as a whole, with that young girl that presented with the non-glomerular that had reflux nephropathy. On average, people like her, since they usually have kidney disease when they're born, about half of them are either needing renal replacement therapy, so either dialysis or transplant, by around the age of 19. And those kids with glomerular disease, since they actually start, the median age in our group, again, these are really 30,000-foot views. The median age of onset for glomerular disease in this cohort was about 8.5. And those kids, if you add 8.5 to this time to when they get 50th percentile, this is 11.8 years from disease onset. They're also about age 19 when they're needing renal replacement therapy. So I think this is a good description, but the other thing that I think of with this, and probably all of you that take care of children who become young adults, and we're trying to help them navigate that transition to adult care providers, many of these kids that we follow are reaching these endpoints right around that same time, or will shortly after we hand them over to the adults. So it's particularly important, I think, to be preparing families for thinking about decline, but also about transition very early, because there's a lot of stuff going on at that age. So overall, if you include other markers of kidney function, and this is the measured GFR, the overall estimate of rates of decline using measured GFR for those kids with glomerular disease is about 8 or 9% per year, and for non-glomerular disease, about 5% per year. So broad brushstroke numbers. Can we do better than that for any particular individual to figure out how they'll do? And so we look at different factors that we know or we hypothesize might be important and associated with kidney function decline. So this shows the Kaplan-Meier curve. So it's the kidney survival probability on the y-axis and the years from study entry on the x-axis. And not surprisingly, where you start as far as level of kidney function is very important. So you have a much shorter kidney survival if you start at a GFR less than 30 than if you start at a GFR greater than 45. That's true for both non-glomerular disorders and glomerular diagnosis. So where you start is important. Level of protein in the urine is also probably the major contributing factor that explains a lot of decline. That's why as nephrologists, we're always trying to bring down that urine protein, either with treating the underlying glomerular disease or ACE inhibitors or angiotensin receptor blockers. But you can see the blue line is a urine protein to creatinine less than 0.5. Less than 0.2 is normal, but for reasonable distribution in the study, we used urine protein creatinine less than 0.5 to 2, so that would be significant, what we call significant proteinuria, and greater than 2, which would be nephrotic range proteinuria. And you see a dose-response relationship with much more rapid decline, both in kids with non-glomerular disease and glomerular disease if they have nephrotic range proteinuria. So level of GFR and proteinuria are very important in predicting outcomes. If you look at all the other factors that we know are associated with chronic kidney disease, another group of factors that may be comorbidity, so they may be caused by worse kidney disease, or may, we think also potential sites for intervention that may help slow decline that we see with progression are protein to creatinine ratio, hypoalbuminemia particularly, elevated blood pressure, another thing we can treat, so that's very important to pay attention to, dyslipidemia, male gender, and anemia. All these were important. If kids had each of these factors, they were more likely to decline even more quickly in non-glomerular disease. And in glomerular disease, similarly, proteinuria, hypoalbuminemia, and elevated blood pressure were the most important factors. And this is an illustration of those factors. And this, for example, if you have a child who has non-glomerular disease, this was published in AJKD a couple of years ago. But this line, this is predicted percent of events-free. So how long do you have until you're going to need renal replacement therapy or half your GFR? If you're a 10-year-old girl with a GFR between 30 and 45, and you had no proteinuria initially, but you developed proteinuria, it looks like at about 5 years, 60% of those kids would still be free of kidney needing renal replacement therapy. If you add to that, this is that same typical child with that GFR less than between 30 and 45, who has proteinuria the whole time, hypertension, and becomes anemic, much more, a higher probability of kidney failure. And similarly, if you have that level of kidney function, persistent proteinuria, hypertension, anemia that doesn't get better, and hypoalbuminemia and dyslipidemia, more than 80% of those kids with those multiple factors are going to need renal replacement therapy in 5 years. So again, we're starting to be able to predict and actually identify putative intervention points for trials. Like if we change these things, can we make kidney function? Can we preserve kidney function longer? It's difficult in an observational study to make those conclusions because we just see associations, but we're trying to launch clinical trials in some of these arenas to see if they can help. So those, as you can imagine, those are fairly complex formulas, probably tough without showing the picture to the family to give them a sense of prognosis. It turns out that level of GFR and proteinuria and cause of kidney disease were the most important things that led to those predictions. So we tried using the data from our CKID study and partnering with colleagues in Europe who'd mounted a study called ESCAPE that was a trial of blood pressure control in children with kidney disease to see if we could group this data and make a clinically useful tool for people if you're trying to counsel families on what to expect. So we combined the data from the CKID study and ESCAPE, and we had a total over, this was a couple years back, over almost 1,200 children included in this. And we grouped them. There's an organization, the Kidney Disease Improving Global Outcomes, KDIGO organization, and in adults, they had developed a staging system that was based on level of GFR and level of, they use albuminuria in adults. In kids, we use albuminuria certainly in diabetes, but we more often use level of proteinuria. It's more readily available. Children, actually teenagers, often will have albuminuria in the morning, so it's a little hard to know if that's specific. So we made a staging system. These are the GFR stages. Lowest is here, GFR stage 4, 15 to 30, and then greater than 90 is stage 1 if there's evidence of other structural abnormalities or things for greater than 3 months. And then stratified that by level of proteinuria. And then we grouped these people together until we found areas where they had similar prognoses. So the color codes show overlong, and it kind of goes green is less concerning than red is most concerning. So we grouped the kids that behaved similarly in our observational studies and color-coded according to the strata of level of GFR and proteinuria. And what we found was there was a little bit difference between non-glomerular and glomerular disease, but you could use this tool, like, for example, that first case that I showed you about the girl who declined over time with glomerular disease. When we first saw her, her estimated GFR was between 60 and 90, and she had significant proteinuria. So she was in this light green area. And she had glomerular disease. So if we then use that map, so it's a young woman with glomerular disease, these were the data that led to this prediction model. And young woman with glomerular disease with that straight of GFR and that level of proteinuria, and about 50% of kids who looked like her with just those features had needed renal replacement therapy or have their GFR. Our best estimate is 6.2 years, but it was somewhere between 5 and 7.5. And if we look then back, this is just as a case, at that girl that with those parameters, and we look back, we would predict from our tool was around 6 years. And she had presented at age 15, and around age 21, she had clearly halved her GFR and was actually approaching the need for renal replacement therapy. So a tool that we could use, and you can use in the clinic to try to talk to people about what other kids, similarly, you know, what's true for a population may or may not be true for an individual, but it's a first way to get a handle on what the future may hold for people. And then if we can intervene, improve proteinuria, measure and control blood pressure well, perhaps we can lengthen that. And if you want to use this tool, the great thing was that when we published this article in AJKD, a couple of weeks later, I got an email from someone that I didn't know who was in South America, and he had said, Dr. First, I made an app of your tool, And so if you go to www.ckdprognosis.com and you enter glomerular, and you can do it right now, pull out your phones. I'm sure you're dying to pull out your phones. So you can put in the glomerular, non-glomerular disease, the estimated GFR using the bedside formula, because we know most people have creatinine, and the level of proteinuria, and it will yield those numbers that I showed you, when 10% or 25% or 50% of the people will have their GFR and need renal replacement therapy. So a nice, useful clinical tool. So from the second case, you saw that one of the most challenging things and morbid things that develop in these kids is cardiovascular disease, and I'm including that in the broad sense. So cardiovascular disease, death from heart disease or stroke, and these are really key things in childhood kidney disease. And this is from the U.S. Renal Data System. That's data on all children with end-stage renal disease. And these are the years of life expectancy lost in children with end-stage diseases. So you see, this is a huge impact on people's lives. And, so this is ages 20 to 24, on average, 40 years of life expectancy loss. And half of these deaths, at least half of these deaths, are due to cardiovascular disease, not the kidney disease itself. So these are really important things to address in childhood. And that's something that's been a really important finding in the CKID study. So do you remember that first cohort that I showed you that had a median GFR around 40 and age of 11? Most of those kids had one or two or sometimes three cardiovascular disease risk factors. So think about a population of 11-year-olds walking around that you see in your clinic. They should not have cardiovascular disease risk factors. So this is a real high-risk population. When we take care of them, they're mostly asymptomatic. They have risk, they're asymptomatic. But then as they become young adults and older adults, they become symptomatic. And as I mentioned, death from cardiovascular disease is very common. So what we started to do in CKID was look for evidence of these cardiovascular risk factors, and I'll show you what we found. And again, places where we can intervene to potentially make these kids' lives longer and better. So what's happening, there's probably from a number of factors, from the hypertension, dyslipidemia, other things, there's injury to the endothelium, eventually monocytes and other cells migrate into the intima, and then smooth muscle cells migrate into the intima and change the nature of the vessel wall. Some of those factors that contribute to those injuries that are common in this population are hypertension. This is a graphic showing this is percentile of blood pressure. So in kids, we define hypertension as blood pressure above the 95th percentile in most kids. In children with chronic kidney disease, we want it to be below the 90th percentile. But you can see and these are kids who are selected to be in a long-term study. So we're choosing the people we think are going to come back to clinic, they're adherent with therapy, they have long-standing relationships with their physicians. And even amongst that group, these blocks show the excess blood pressure, hypertension excess in this cohort at baseline. And unfortunately, we can't show that we're doing a whole lot better, even when we follow these kids over time, a little bit better, but we can certainly do a better job with this. We also, in addition to the blood pressure, that was the blood pressure in the clinic when we saw them, we measure ambulatory blood pressure every other year. And if people aren't familiar with 24-hour blood pressure monitoring, you can be normal in the clinic and normal at home, and that's really normal. But you can be normal in the clinic, but high if you do that 24-hour blood pressure, and then we call that masked hypertension. If you're high in both settings, then it's confirmed or sustained hypertension. So in the CKID study, we applied 24-hour blood pressure monitors to all these kids, and our definition of masked or confirmed was masked was normal in the clinic, but then either the mean blood pressure or the load, so the percent of the time that the blood pressure was higher than a certain level was high, and 25% of the time that was called masked hypertension, and confirmed was abnormal in both. And we saw that even of those kids who looked normal in the clinic, there were, this is the APPM, of those that were normal in the clinic, there were a fair number, a third of them, who were not normal on 24-hour blood pressure monitor. So this is something, it's not part of hypertension guidelines that came out from the ADP to frequently monitor these kids with 24-hour blood pressure monitors, because you can easily miss hypertension and mass hypertension in this population. We also saw that there was a dose-response relationship, so not just that the blood pressure is high, but you could actually see target organ damage. So between normal, masked, and confirmed hypertension, you saw a dose-response relationship with left ventricular hypertrophy. So there's evidence that this is a meaningful marker and something that we can treat to prevent target organ damage in these children. And among those with masked or confirmed hypertension, even in the study, and again, these are kids that are regularly seeing physicians, a third of them weren't taking antihypertensive medicine. So again, clear opportunity for improvement. And those that were taking particular angiotensin receptor blockers or ACE inhibitors were much, much more likely to have a normal 24-hour monitor than those who didn't use them. So again, we should start these and continue these, particularly if we see mass hypertension, and perhaps target a lower blood pressure. And the things that were associated with having higher blood pressure and mass hypertension were elevated protein-creatinine ratios and lower GFR. And the urine protein-creatinine ratio was particularly important. So this illustrates what I mentioned about the prevalence of target organ damage. So this is from our echocardiography in the study, and you can see that at baseline, 15% of the kids with glomerular disease has LDH, and just 11% of the non-glomerular kids. So again, pretty high evidence of target organ damage. And if you look, a fair number had evidence of abnormal left ventricular geometry, and some, and even, again, these are otherwise asymptomatic kids, median age of about 11 years old, not with other heart disease, also had evidence of an abnormal shortening fraction, and some evidence, this was early, but something we continue to follow, of diastolic dysfunction. So again, evidence of target organ damage early on in this population. We also measured carotid intima-media thickness, so really very early precursor of atherosclerosis. This is the normal kids, same age, race, and sex, and the median and distribution, this modified box plot, as I mentioned, of carotid intima-media thickness. And this was what we saw in 100 kids in the C-KID study, so it looks like a shift. Again, very early seeing evidence of target organ damage as perhaps modifiable. And the things that we saw that were associated with that were hypertension and dyslipidemia. So again, particularly hypertension, something we can treat. Dyslipidemia, which we can try to modify, sometimes more difficult to treat in anybody with proteinuria. And it seemed, particularly in the kids with glomerular disease, these blue dots, this is the carotid intima-media thickness over time. So years from CKD diagnosis. So again, this is something that if we think that most of the time these children who become adults, they're manifesting symptoms of their disease and sequela when they're young adults. This is all developing when they're under our care. So again, something that we could potentially intervene to really improve long-term outcomes. Another measure of vascular health that we use in the C-KID study is pulse wave velocity. So the pulse wave velocity measures aortic stiffness, and this is a schematic. So the heart pumps, the blood goes down the aorta. Your vessels should be relaxed, should be pliant, and normally with the pulse wave, the vessels, if they're healthy, should be able to absorb some of that pressure. And if they're much more stiff, and it's been shown in adult CKD associations with things like hypertension and hyperuricemia, that may increase that stiffness. It turns out that if you have a stiff vessel, actually the pulse will be faster. So you can measure the distance from the carotid to the femoral, and then just do the length over time and measure the pulse wave velocity. And this is what it looks like. The procedure, we do this in the C-KID study, higher values, so it's moving faster, stiffer vessels, and that's something we don't want to see. And it's been shown in adult studies, these are actually general population studies, but a clear, consistent association with a faster pulse wave velocity, stiffer vessels, and combined cardiovascular events, so stroke, MI, heart failure. And you can see pretty much across these studies, the estimates are different, but overall, there seems to be a clear and fairly consistent association when you try to combine these studies. The risk factors in adults with CKD that are associated with stiffer values are here: older age, lower kidney function, glucose, higher glucose or diabetes, both of those, and some association with race, and these are independent of each other, and also with blood pressure. We looked in the CKID study at the first 90 kids. This was introduced later in the study. The actual range of disease was more mild here, so over half of them had GFRs between 45 and 90, so and even actually above 90. So these were actually more mildly affected kids in our first look at this. And we did see, similar to the adults, that older age seemed to be associated with a higher pulse wave velocity, but these are really not that distinguished from normal in this group. And we did start to see within our group some association with glomerular disease. If you look, this is the standard deviation score, so if it was a perfect normal distribution, and this is pretty good, the mean would be at 0 and around that. And so this is the non-glomerular kids. At this age, we didn't see a big shift from normal. We did see what seemed to be a suggested shift from normal in the kids with glomerular disease, most driven by elevated proteinuria. This is pretty mild, not very impressive. But we have colleagues, colleagues in Europe that I mentioned that did the ESCAPE study, have done a similar cohort study in children with chronic kidney disease. It's called the 4C study, children with CKD. These children have more advanced disease than the CKID study. I think the median GFR is more like 30 than in our group. And in pulse wave velocity in that group, they've been able to show both. Actually, this is carotid intima-media thickness, and this is pulse wave velocity. Starting, this is age. I don't know if you can see this. This is from 6 to 18, similarly here. And these curves represent the normal reference values for children. So for carotid IMT, this is the 5th, 50th, and 95th distribution. And you can see in their cohort, really pretty, again, these kids are young. These are pre-pubertal children largely. So really, with CKD, pretty dramatic increases very early on in the distribution of carotid intima-medial thickness, and also some increase, perhaps not as dramatic actually of the carotid intima-medial thickness, but some increased suggestion of at least a subpopulation of this group with really elevated pulse wave velocity. So again, evidence that cardiovascular disease risk is present and evolving in front of us. So important areas to intervene in this population. So I think I've come to the end of my time. I just wanted to sum up with a couple of take-home points for the generalists in the audience. First of all, for all of us as adults, this is World Kidney Month, and the 14th is World Kidney Day. So for you and your families and friends and acquaintances, just remember kidney disease is very common. People should know their blood pressure, know their kidney function, make sure that that is something that's being treated. Most kidney disease in children is due to structural abnormalities, congenital abnormalities of kidneys and urinary tract. Cardiovascular disease risk factors are very common in this population. This is something that we cannot ignore, and we need to intervene to promote long-term health in this group. Take-home point for assessing kidney function, you can use the 0.413 times the height over creatinine or the 80.5 over the cystatin C to estimate kidney function at the bedside. If you have both, the combined kidney function is best. There are pediatric GFR calculators of the National Kidney Foundation if you go to www.kids.kidney.org. And if you want to use our app for the estimated GFR, cause of kidney disease, and level of proteinuria to predict time till needing renal replacement therapy, you can go to ckdprognosis.com. It's really very useful application. And we should all keep in mind that in addition to trying to maintain kidney health, we should be very aware of cardiovascular disease risk in this population. We need to measure blood pressure. We need to measure, as in the new guidelines, ambulatory blood pressure monitoring in this group. at regular intervals and treat both elevated blood pressures and masked hypertension aggressively. The targets from the intervention trials are actually to treat folks to about the 50th percentile for their age, sex, and height. So I thank you all for your attention. I know you just switched to earlier grand round, so I appreciate your being here. And thank you very much. I'm happy to take any questions. Thank you.
Susan, that was great. Thank you so much. So helpful. The thought that came to my mind is, with all of this, are we becoming more aggressive in doing transplants earlier? Or what's the implication from your perspective about that?
Yeah, I think that, it's a great question. I think that, unfortunately, even a transplant is another form of chronic kidney disease. Even when we've now in the CKID study, our initial study ended at initiation of renal replacement therapy, but we continued to follow folks passively and did estimates of GFR. Now we're starting to measure post-transplant, but even good transplants, if you measure the GFR, is like 70 often. So again, it's another stage of chronic kidney disease. So I think whatever we can do to preserve kidney function and to treat cardiovascular risk early on is going to be helpful, because those risk factors are going to persist and perhaps even accelerate with some of the other therapies that we use to maintain transplant health. So it's a great question, but I think at this point, if we can maintain kidney health and treat the cardiovascular disease risk factors, we're doing the best we can.
Quick question. Is there any work in the line of stem cell therapy for kidney, especially the...
There are in transplant. There's some work, people thinking about doing combined, like partial stem cell therapy at the same time as you give a transplant to try, our holy grail is promoting tolerance. But as far as I know, and you mean stem cells into the kidney?
Well, your comment that some of the nephrons in one side of the disease take a big hit, yes. So that seems like it would be a pretty quick.
Yeah, so I do know of a trial that's starting, that's been used in some adults with diabetic kidney disease, trying to introduce stem cells. The data it's very appealing theoretically, but the data going into it hasn't been that strong. And yet, as you could see, actually, a real challenge for us also is, even when you directly measure GFR, there's so much variability that in the preliminary data I saw from that trial, the people who were real cheerleaders wanted to say, oh, it looks like it's better, but you don't know if the variability is just the normal variability over time. So it's tough. It's a great thought. I think it's probably in the future, but as far as I know, it's really in its infancy.
So, Sue, that was a fabulous talk. I wonder if you could comment on this issue of proteinuria, because in adults they do measure albumin, and it's thought that this is representing some damage to the glomerulus, et cetera, et cetera. And in kids, particularly with non-glomerular disease, it's very often tubular protein, and it's lower molecular weight. And so it seems like there might be different pathophysiologic mechanisms. Could you comment on us using this marker of proteinuria, but it might have two different sources and two different sets of mechanisms?
Yeah, you described it beautifully. So we think proteinuria is predominantly glomerular, and the albumin is the main protein in proteinuria when we measure it. The lower molecular weight proteins would be other than albumin. It may be that there's information if we use both. In some preliminary, we added albumin measures to the CKID study later than the proteinuria measures, and on first pass, it looked like that we didn't get any, as far as prediction, we didn't get any additional information. It looked like it was very similar, but we're going back to look at that in different ways and see if we can get added value by using both measures or other measures. I do also want to say there's other biomarkers of tubular injury. That CKID is now part of a larger consortia of adult cohort studies, and we're looking in kids at a number of the tubular injury biomarkers that have been shown to predict like acute kidney injury in adults, and some CKD, and actually some of them are showing some promise. Some markers, it's pretty exciting, for tubular injury seem to be adding predictive value in those kids with non-glomerular disease, and markers of inflammation and podocyte injury seem to be adding value in the kids with glomerular disease. So it makes some biologic sense as well, but it's a great point.